So the program is designed to improve quality and safety of care for patients that have Parkinson's that come into a hospital and are inpatient for any reason. And that's usually not because of their Parkinson's disease. It could be a planned surgery, an infection, and it's a program that Dr. Walter and my colleague Shannon, who's also a nurse practitioner, Shannon Schaefer, had done for a while, the intervention part, and then with a grant from the Parkinson's Foundation, they more standardized it, made more changes, and are actually doing evaluation of the program. So what we do is we created an inpatient team that consists of myself and Shannon, so two nurse practitioners. And we have about 2 hours of our day total. So she does it 3 days a week, I do it 2 days a week. So it's about 10 to 12 hours of clinician time a week. And so we created a census where we get a list of anybody in the hospital that has Parkinson's, Parkinson's disease, Lewy body dementia, anything like that in their history. So not necessarily their admission diagnosis. And so what we do is we confirm their diagnosis. We usually read one of the last notes from their neurologist. We'll look at their medication and see what their most recent home regimen is. And then we go to their hospital chart and we make sure that their hospital medical record, that their schedule matches their home regimen. So typically medications are maybe ordered like 3 times a day, 4 times a day in the hospital, and those kind of default to certain times. We make sure that those times are specific to the patient. So one of the changes that we made is that a hospital provider has to enter those as custom times. They can't just say 3 times a day and it defaults to hospital times. They have to specifically enter, say, 9, 1, and 5. And so that helps keep patients on their home regimen. We try to intervene if, say, someone is in the emergency room for several hours. We make sure that as long as it's not contraindicated, that they're still getting their home regimen. They're not missing doses. And we make sure that patients aren't ordered or given any contraindicated medications. So there's a lot of medications that are used for nausea, for confusion, that are actually can block patients' Parkinson's medication and make Parkinson's symptoms worse. And so we look at charts every day and make sure none of those are ordered. So with that kind of list of patients that we get and monitor, for about 40% of those patients, it's really just monitoring, looking every day. Nothing's contraindicated. There's nothing going on that we need to intervene with. And then with 60% of those patients, kind of over this past year, we've actually had to intervene. So contact the provider, let them know, you ordered compazine that's actually contraindicated. Maybe suggest that they change their timetable so they're not getting, their last dose of Cinemet, when they've been asleep for 3 hours, and getting it then when they need it. And then also managing things like dysphagia, making sure people are getting up and active as soon as possible, getting moving. Things like constipation, recommending regimens if they can't be on their particular Parkinson's regimen. And so that was about 60% of cases. So kind of what we're looking at, part of what my poster says is when we intervened. So obviously, the intervention is needed and it's doing something. But looking at kind of those broader like hospital and system changes that we made, like changing so alerts come up, changing so doctors have to, so providers have to enter the medication schedule regularly, seeing if that kind of diminished over time. Because those kind of corrections now, a lot of them are happening before we even see it.